Hi everyone, my name is Dan Marsala, and this is my Week 2 presentation on cardiac function and how it relates to mechanical ventilation. So mechanical ventilation, it's obviously our bread and butter of being a respiratory therapist. It's kind of one of our primary job roles in the ICU. Mechanical ventilation can have some pretty profound effects on cardiac function. And in this discussion, we will explore the topic of mechanical ventilation in the ICU setting, and how and why it can negatively affect cardiac function, and how cardiac function can be used to determine if an SBT will be successful. So what is cardiac function? Cardiac function is the ability of our hearts to meet the metabolic demand of our bodies by delivering oxygenated blood and removing cellular waste products. So oxygen demand increases due to elevated metabolic needs that can occur from things like stress, disease, physical exertion, and the body can meet this increased demand by two ways. The first of that is increasing oxygen levels in the alveoli, which increases the saturation levels of the blood. And we can do this with mechanical ventilation. We could do this with mechanical ventilation by increasing the FiO2, or by increasing the PEEP to increase alveolar recruitment. And then the other way is to increase perfusion to the tissue. So to increase perfusion to the tissue, heart rate increases, and with heart rate increase, that equates to increased stroke volume. So what is stroke volume? This is the blood that is ejected from the ventricle during systole. It can be affected by the force of the ventricular contraction and the volume of blood that fills the ventricle. So what are some common ways that we assess cardiac function as respiratory therapists in the ICU? The first and the most common way, or the most basic way, is palpation. This is just physically feeling for a pulse. We're going to do this pretty frequently, especially with doing things like arterial blood gases, because before you stick, you're going to feel for that radial pulse, and do your draw. So there's one estimation that if cardiac function is impeded and it causes a drop in blood pressure, if the blood pressure is below systolic of 80, you will no longer be able to feel the radial. If it's below 70, the femoral pulse, and if it's below 60, the carotid. The next way is oscillatory blood pressure measurement. This is one of the most common forms, and it uses an inflatable cuff and stethoscope. So when you inflate the cuff, it's to the point that it actually stops that arterial flow, so you can't hear it with the stethoscope. So as you release the cuff pressure, the very first sound you hear, which is called Korotkoff sounds, the very first time you hear that pulsating sound of the pulse, that is your systolic pressure. And as you release the pressure further, the last sound you hear, which before you can no longer hear the pulsating anymore, that's your diastolic blood pressure. So the next way we assess cardiac function is through oscillometric blood pressure. So this is your automatic inflating blood pressure cuff that you see pretty much on almost every patient that's in your ICU. It's connected to an oscillometric blood pressure monitor, and this measures the pressure waves associated with those Korotkoff sounds. The next way we see pretty frequently also is arterial lines. This is commonly used in patients that are more critical, like those with ARDS receiving mechanical ventilation or those requiring vasopressors. So this is a cannula that's placed in the artery. It's most commonly in the radial artery. It provides continuous blood pressure measurement and mean arterial pressures. It detects the blood flow and the pressure exerted from each contraction in the heart, which is transmitted through the cannula into a fluid-filled rigid tube up to the transducer. And these are very beneficial because it allows for lab draws and as well as to draw blood for blood gases, so you don't have to repeatedly stick the patient. And this also will help reduce the occurrence of infections from the reduction in blood draws. So why is cardiac function important with mechanical ventilation? So as you know, the heart and lungs work really closely together. They are integral in meeting the oxygen demand for our bodies. If the demand is impeded in any way, hypoxia occurs and cell and tissue death rapidly follows. So in critically ill patients, interventions that focus on improving the function of one system, such as oxygenation through mechanical ventilation, can have a negative effect on the other system. So how ventilation can influence cardiac function? So through both spontaneous and mechanical ventilation, changes occur in the intrapleural and intrathoracic pressures and lung volumes. This can affect cardiovascular performance, such as preload, afterload, heart rate, and myocardial contractility. When changes in intrathoracic pressures occur, these things are transmitted to the intrathoracic structures, such as the heart, the pericardium, and the great arteries and veins. So positive pressure ventilation causes an increase in intrathoracic pressure, which causes an increase in right atrial pressure. When you add PEEP to the mix, it increases the pressures above, and they remain greater than atmospheric pressure throughout the whole respiratory cycle. So these changes in pressure can have an even greater effect on patients with vascular pulmonary pathology and congenital heart disease. So as intrathoracic pressure increases during positive pressure ventilation, venous return decelerates, and right ventricular preload and cardiac output can fall. So in patients with ARDS that we're seeing frequently with COVID pneumonia, we're using the ARDS protocol frequently with, and a lot of these patients respond pretty well to the high PEEP table. So in some of these patients, we're using PEEP levels as high as 18 and even 20. And when you are using PEEP levels as high, it's really, really important to monitor that cardiac function because of that potential for reducing venous return and causing that right ventricular preload and cardiac output to fall. So in patients with impaired myocardial function, when you discontinue positive pressure ventilation, either through extubation or when you start them on a spontaneous breathing trial, this can actually cause an acute increase in afterload in the presence of poor left ventricular function. So when they aren't getting that high levels of positive pressure, that increase in afterload can actually cause a congestive heart failure exacerbation. So on to the next part, cardiac function and spontaneous breathing trial. So during spontaneous breathing trial, one thing that we closely monitor to determine if, one, it's possible to begin, and if it's successful, is blood pressure. So if a patient is hypotensive, hypertensive, or requiring a high level of vasopressors to maintain adequate blood pressure, then it's advisable not to start a spontaneous breathing trial, because obviously whatever disease process that is causing these fluctuations in blood pressure or the need for blood pressure support isn't relieved yet. So once you can get those blood pressures to normal levels, or the need for vasopressors minimalized, then you can begin to consider a spontaneous breathing trial. So during a spontaneous breathing trial, one thing that we actually monitor is systolic blood pressure, and to see if there's any changes with it. So when you switch that patient over to CPAP with pressure support, if you have a change greater than 20% from baseline in systolic blood pressure, then this is pretty indicative of a failure. So this change could be caused just from the stress of it. Sometimes patients are weak, and just that stress of having to breathe on their own can cause stress and increased demand, so their blood pressure increases. Or again, that acute increase in afterload there from switching to CPAP, and removing that positive pressure ventilation can cause that blood pressure to spike because of a CHF exacerbation. So lastly, a pretty interesting study that I found about central venous pressure in spontaneous breathing trials. There's a study of 204 mechanically ventilated patients who was assigned to SBT. And they used an assessment of central venous pressure at baseline and then 2 minutes after the start of the spontaneous breathing trial to see if there was any correlation between an increase in central venous pressure and extubation failure. So 165 of those patients were extubated, and 11 of them were reintubated within 48 hours. So in those that failed extubation compared to those that were successfully weaned, they found that there was a significant change in central venous pressure from baseline, with those failing having a much higher central venous pressure after 2 minutes of the SBT. So this could actually be indicative of cardiac failure due to that massive increase in venous return following the continuation of or discontinuation of positive pressure ventilation. So a couple questions. The first is, in what ways can mechanical ventilation impede cardiac function? And second is, if a patient's blood pressure spikes greater than 20% from their baseline during a spontaneous breathing trial, is it advisable to continue that spontaneous breathing trial? Well, I hope you enjoyed my presentation, and I look forward to seeing yours. Have a good one. Thanks.